we talk about myopathies now. So whenever you have a patient who comes in with weakness, I think even in primary care, it's your job to really localize where the lesion is. And I think that, neurologists are obviously very good at this, but I still think, especially if you're in residency or in primary care, you should really understand the process of how a muscle fiber, where kind of things can go wrong, right? So obviously we know that the upper motor neurons will start in the sort of the pyramidal cells up here. They will cross over in the midbrain, go down in the spinal cord, intercalate with the anterior and in the anterior horn cells with the lower motor neurons, and those will spread and innervate the skeletal muscles. And really, at any point along this branch, you can have weakness, or excuse me, some sort of deficit that can lead to clinical weakness. So let's just briefly think about what are the things that could kind of go wrong, right? So obviously, we're not going to go over this, in detail, but right, if you have someone, if you're worried someone's coming in weak, if you're worried about a myelopathy, right? So spinal cord involvement, right? You look for, it's usually bilateral. Usually they're both motor and sensory changes. Often there's bowel or bladder dysfunction. And often you'll get some sort of abnormality on your reflex testing, for example, right? In contrast, if you have someone who has an anterior horn cell problem, right, like ALS, you'd look for fasciculations, and because it affects the lower motor neurons too, you'd look for loss of reflexes, right? In contrast, let's say you had someone you thought had a peripheral nerve problem like GBS, right? You'd see these changes in a very specific sort of ascending involvement pattern. If you had a neuromuscular junction problem, you'd look for sort of fatigue of weakness, right? So worse at the end of the day. And then typically, although sort of not exclusively, muscle problems will affect mostly the proximal muscles first, although there are some exceptions to that, which we'll talk about a little bit. So again, I think, if there are a bunch of takeaways that I'm going to stop at and talk about during this talk, but I really want you guys to take away the fact that, if someone comes in and they're endorsing weakness, there's a lot of different places that it can go wrong, and really you should know how you're going to ask them questions and do your exam to really sort of to try to isolate where that going wrong process is. We'll talk about the history, myopathy, blah, blah, blah. Okay. All right, so let's talk about the first case. So we have a 25-year-old male, and he was sent by his PCP for a CPK of 487. And so it's a big red abnormal on the labs. It was originally checked because he had some pain in the right shoulder with abduction. When you do your exam on him, it's basically unremarkable. He does still have some pain and abduction of the right shoulder, but you don't see any motor abnormalities. So he's 5 out of 5 throughout. His sensory exam is normal. His grip is normal. He can walk okay. There's no atrophy that you notice. Okay. So remember, the CPK is the one we check most often, but there are actually 5 different enzymes that can be abnormal in myopathies, right? So the aldolase, the transaminitis, and the LDH. There's always a tail of someone who gets a liver biopsy for elevated AST or ALT and end up having a muscle problem. So if you have someone with what is described as hepatitis, just make sure you check the CPK as well in that particular process. What is the CPK? Well, the CPK catalyzes the conversion between ATP and ADP, using sort of phosphocreatine as a buffer, basically. And this occurs in tissues that use a lot of energy, right? So skeletal muscle and the brain, for example. The CPK exists as a dimer, right? Either as a homodimer or a heterodimer. Homodimer mostly in skeletal muscle, for example. Interestingly, if you have chronic muscle disease, you get a little bit of a shift from MM to MB. So probably because when you have regenerated muscle, it sort of goes back to sort of the fetal muscle process, which has a lot of MB in it, for example. The CPK is usually tested based on enzymatic activity. So you'll actually get, it's not a number, you'll get a units per liter, essentially how many units did it take to convert this ATP to ADP. And then in cardiology, right, if you want to test specifically for the CKMB, it's antibody to the skeletal muscle. So here's the question I think I want to propose to everybody. What is a normal CPK and what does normal mean, right? And how do we get, on our lab tests, what makes a lab quote considered normal or not? And I think, to be frank, a lot of it is arbitrary, right? So if you have a patient who, I have a patient I'm seeing later today, and she has an ALT of 36, right? And that's considered abnormal based on whatever lab she went to. And so she wants to talk about her, quote, transaminitis, when I think it probably, a normal does not, is something that is, quote, abnormal probably does not always mean pathologic, for example, right? Like if you have a potassium of 5.1, maybe that's, quote, abnormal, but you're not going to have any harm from that potassium, for example, right? So I think a really interesting thing to think about is so most labs are sort of assumed to exist in this particular curve. So this is called a Gaussian distribution. And what that means is you basically have this bell-shaped curve where 95% of the population sits within 2 standard deviations of the mean. So like height, for example, would be an example of this, right? So, someone who's like 5'9" or 5'10" sits here. And then, someone who's 6'8" sits over here, and someone who's like 5'0" sits over here, at least in males, right? But what is the CPK actually exists? And so because of that, you'll get these, and that's sort of what often the lab tests are based on in terms of what is normal, abnormal. So this is a patient who, and that's kind of where this comes from, is that the labs are sort of standardized in often just a median group of some population, and then assumed to exist in this Gaussian distribution. And so because of that, you'll get something like this, right, where you have someone who has a 501 CPK, and you get this critical value sort of notification that I've seen. But what the CPK actually exists in real life is sort of this non-Gaussian distribution, meaning that it peaks, at some point, and then it also, there's this long tail of people who essentially have no evidence of any muscle or any other sort of neuromuscular problem, but just have higher levels of CPK, probably because of increased production or decreased clearance. But either way, it's not actually pathologic in any way. And I think that's really important to note when you ask about when someone comes to you with an elevated CPK. The other thing that's really, really important to note is that there's a very, very interesting and strong racial predilection for CPK levels. So African-American patients in particular at baseline have a much higher CPK levels than whites, and also Asians and Hispanics seems to have a little bit higher CPK levels as too. So this is from the NHANES study. So this is a study of thousands of patients from a couple of years ago looking at their CPK levels baseline. They found that, essentially in white patients, white men, that in the 95th percentile, the average was, the 95th percentile was bordered by 312, whereas for African-American males, it was bordered by 712, right? So much, much different, different based on race as well as sex as well, right? So you can see that men have much higher CPKs kind of at baseline than women. This is, I think, a really, really important study, and again, something to think about when you're looking at a CPK. So we know that exercise will elevate CPKs. So for example, our esteemed Dr. Murphy, remember, told me that when he did a marathon a couple years ago, and he tested his CPK a week afterwards just for fun, and it was still 6,000. So I think there are a number of lessons from this particular table. So this is a study of American military recruits on day 0, and then after 7 days of basic training. And so there are a couple of messages to this chart. So number one is, again, African Americans at baseline have a much higher CPK levels than often other races. Number two is that for all races, the mean is much higher than the median. So what does that tell you? Again, that tells you that there are people who, again, just exist at a much higher CPK than the rest of us. And then again, for everybody, after 7 days of exercise, the CPK level is shot kind of through the roof. So again, if you have someone who you're wondering, like, maybe is that CPK abnormal or not, and they are, highly active, you can say, hey, maybe just take a break from exercise for 3 or 4 days, and then we'll recheck it, for example. As sort of a personal note, I've found that in these patients, the aldolase will usually be normal. And so that can kind of be reassuring to you and the patient as well. So this is really striking. So this is actually guidelines from some European neuromuscular group. And I was always shocked by these numbers, but they say if you have someone with what they call hyper-CPKemia, or high levels of CPK, and they're asymptomatic, right, you don't need to work it up anymore if the number is greater than 1.5 upper limit of normal, based on these numbers here, based on the data that I've showed you. So I always thought this is quite higher than I would even expect. And I'd still be nervous if I had a patient who had a CPK of 900, even if they're asymptomatic. But this is their recommendation. Just to show you that, again, In someone who's asymptomatic, typically a high CPK is not anything to worry about. Now, again, I want to be clear, this is asymptomatic. So I remember I did have a patient who came in weak, and he was African-American, and his CPK was like 600, and he was dismissed by some physician because they said, oh, well, black males have higher levels of CPK at baseline, which is true, right? But it had nothing to do with this particular patient, right? He was weak, right? And so then therefore he needed more of a workup, and he ended up having, I think he had some kind of muscular dystrophy as an adult. So anyway, so the first takeaway that I want everyone to realize, this is sort of the second takeaway, is that there is a wide range of normal CPK values, right? So again, how exactly any lab comes up with a particular upper limit of normal is quite arbitrary. And remember, the CPK exists in that non-Gaussian distribution where a lot of people who are normal and have no neuromuscular disease will have CPKs of 500, 600, 700, et cetera. In these particular patients, just as that I found, the aldolase can actually be helpful, and they're often normal in this set. And then remember that post-exercise, the CPK will elevate in normal subjects. So if you have someone who you're worried about, or at least want to confirm that you don't think it's unremarkable, right, then you can just have them recheck after being not exercising for a few days. All right, case number 2. Are there any questions about that first case?
Hi, Dr. Bonker. This is med student. I was just wondering.
Med student, do you have a name?
Janae. I do have a name. Yeah, it's Janae. I was just wondering if you know what explains the differences in CPK levels among the racial identities.
No. Well, so they've actually found that it has nothing to do with weight or body type. They think it's more due to a production or clearance issue.
Okay.
It has nothing to do with like muscle mass or anything like that.
Okay. And then I was just wondering if you know how within the studies African American is differentiated from Black identity, or if it is listed at all.
It's not listed. Yeah, the reference is there if you want to take a look. Let me see where it is. This is it's a pretty famous. Yeah, it's George in medicine. This is the Hopkins Journal in 2016.
All right, thank you.
But this is based on N. Haynes, so so this is just self-report.
Okay, thank you.
So like this is a very famous like like they do this kind of very famous interview every year where they call thousands and thousands of people. So there's very standardized sort of like way to do it. And then question about, yeah, exactly. So the patient with right shoulder pain without weakness would not consider to be symptomatic, right? So in that particular patient, I would provide reassurance, right? Okay. So case number 2, we had a 40-year-old male referred for leg pain and elevated CPK to 650. So he's describing kind of achy pain in the right calf and posterior thigh with activity, for example, when he runs, without any sort of clinical weakness or any sensory changes. On exam, this is clearly not me. I took this from a paper, but because I don't really do a lot of reflex testing, but they noted decreased right Achilles reflex, but otherwise it was generally normal. So again, I think you'd want to think about what could be weak in this particular point. So this guy went for an EMG. And again, another really important takeaway that I want you to know is that an EMG, again, the purpose of the EMG is, again, to help localize where the lesion is. It does not give you a diagnosis. So the point of an EMG is to say, is this a myopathic process? Is this a neuromuscular junction process? Is this a radiculopathy? Is this a motor neuron disease? But an EMG is not going to say, excuse me, this patient has dermatomyositis versus, this patient has a myopathy secondary to a statin, for example, right? I mean, sometimes there are a little bit clues, but in general, the point of the EMG is to localize where along that process the weakness is occurring. So, it's also important to remember that if there are no myopathic changes, it does not completely rule out a myopathy. And sometimes they can, if you have a really good EMG person, they'll do the thoracic paraspinals, which can often be abnormal in myopathies, but that's neither here nor there. I think the point of the EMG is, again, in this patient, the patient was found to have a S1 radiculopathy. And on an MRI, it did show some root impingement on the L5 and S1 nerve root. So there are neurologic diseases that can present with an elevated CPK. So this is a patient with ALS and who has tongue fasciculations. So ALS on the rheumatology boards every year, but at least it's very frequent for someone to come in with weakness and a CPK of 600 or something like that, and the diagnosis ends up being ALS, and you make it based on these fasciculations or tremors, right? But other neurologic processes can cause an elevated CPK, such as radiculopathies, for example, that our patient had. So again, takeaway number 2 is that you can get mild CPK elevation. You wouldn't get a CPK of 50,000 from a radiculopathy, but sort of mild CPK elevations can be seen with neurologic diseases. And again, the EMG will help localize where the lesion is, but it's not in and of itself going to give you a diagnosis, right? So I always tell my residents and fellows that these imaging studies, pathology, EMG, et cetera, they can help, but the actual final diagnosis really ends up on your shoulders, right? You're the one who has to make the final diagnosis. All right, case number 3. So a 62-year-old male, he has long-standing diabetes, and he's presented with acute onset of right thigh pain. So he reports that he was sitting on his bed, and then I'm trying to remember this case. This is actually a real case that we had. Sitting on his bed, and as he's sort of standing up, he suddenly developed severe pain in the right thigh. So he came in the hospital because of this, and he had difficulty ambulating. On our exam, he had difficulty lifting his right thigh because of the pain, but his left leg, left arm, and bilateral arms were all completely normal. Sensory exam showed a little bit of like a tiny sort of stocking glove pattern neuropathy, probably due to his diabetes, but otherwise was normal. And a CPK was 735. So his team got a thigh muscle MRI, and it showed multifocal and right thigh muscular edema, including the right iliopsoas edema, which is compatible with myositis. The presence of psoas edema could contribute to the patient's unilateral right hip flexion dysfunction. So, well, this is just a picture of muscle edema. This is obviously not this patient, because this patient only had on the right side, but edema on the MRI, basically you look for, if you want to look for edema on an MRI, look at the STIR sequence. That's a sort of a fat suppressed sequence. And you can see here that these muscles have essentially bright signal on the STIR sequence here. So this is, again, if you just looked at the right side of this particular picture, that would what this patient's MRI would probably look like. The reason I like muscle edema a lot is because in rheumatology is because we can use that to track how much active inflammation there is, and see if we need to escalate or de-escalate immunosuppressive therapy based on that. So, for example, let's say you have someone who has, dermatomyositis. You give them immunosuppression. They're still feeling pretty good, but not great. Maybe they're not back to 100% baseline. Is their current weakness due to the atrophy that they suffered before in the setting of this inflammation, or is there active inflammation going on now? And using MRI can help you differentiate this process, which is obviously a very important question, right? Whether to increase or decrease immunosuppression for any patient. So that's why I find it quite useful just in my own practice. But in this particular case, right, so the question I was hoping someone could answer is, what would be the best next step for this patient? So who can anybody tell me if they, so I'll give you some choices, right? So option A would be like do nothing. Option B would be to do a muscle biopsy. Option C would be to treat empirically with steroids. Option D would let's say give IVIG. What would people do? All right, is anybody actually there? Okay, got a chat. VHC residents, everyone, steroids. Well, here's my question is, do you think that, does this guy have an inflammatory myopathy? Is this the picture of the myositis? Yeah, I mean, not at all, right? So what could this be? So the team tried to was sent him down for a muscle biopsy and then called us. So if I had seen this patient earlier, I would have said there's absolutely no point in sending this guy for a muscle biopsy. Again, think about what you expect to find. This guy does not have a inflammatory myopathy, right? This guy just had sudden onset of acute muscle pain in one side, right? This guy clearly had something called diabetic myonecrosis. And so diabetic myonecrosis is a consequence of often seen in patients with long-standing diabetes. Usually it's very painful, but it does sort of get better on its own over a few weeks. But it'll show up with very severe muscle edema on the MRI. So again, importantly, the muscle edema is a non-specific finding that can be suggestive of myositis, or at least I think it means essentially muscle inflammation, but it doesn't necessarily tell you what the inflammation is from. And in this particular case, the muscle inflammation is from ischemia, right, that the patient is suffering because of the long-standing diabetes. And so I think it's really important to point is two things, right? So number one is muscle edema on the MRI is not necessarily specific to an inflammatory myopathy. So you can actually get it from some neurogenic atrophy sometimes. You can get it from trauma, right? So let's say you had, if you have, let's say you did a lot of cocaine and came in with rhabdomyolysis, right? You'd have a lot of muscle edema on your MRI. And really, really importantly, and this is, again, a really big takeaway that I really stress on my fellows and residents, is that if you're going to send someone for any kind of procedure, right? So a study, either an imaging study or a biopsy, again, think about what you'd want to find before you send the muscle biopsy. And this comes up a lot if someone comes in with rhabdomyolysis, right? So if you talk to a neuromuscular pathologist, right, in the setting of acute rhabdo, the muscle, you're just going to see muscle necrosis on your biopsy. It doesn't help you necessarily figure out what it's actually from, right? You know there's muscle necrosis on the biopsy. So if someone comes in, if they were running in their first marathon, it was really hot and they decided to run it in some crazy outfit and they got super hot, their muscle biopsy is going to be the same as if someone who came in with a crush injury or someone who, again, did some sort of toxic substance or something like that. So again, just make sure if you're going to send someone for a procedure, make sure that the procedure is actually going to change your management in some particular way. And change management doesn't necessarily mean change your therapy. It could help the patient with prognosis or something like that. But make sure it's going to actually help you answer your clinical question. So in this particular case, the muscle biopsy just came back as non-specific, and again, didn't help us at all in this particular patient. So he fortunately did fine. He didn't have any complications for the muscle biopsy, and yes, it's generally a very safe procedure. But I would have hated to have had this patient get a unneeded muscle biopsy and then suffer a complication from that particular case. All right, case number 4. So we have a 56-year-old female, and she's endorsing some proximal muscle weakness with mild myalgias and cramps for 3 to 4 months. She does endorse some other symptoms, right? So she's endorsing some weight gain, constipation, some paresthesia in the hands. She's bradycardic on exam and has some deficits that you can note in her muscle strength. She has a CPK of 400. And an EMG, again, shows some median nerve neuropathies and no myopathy. And this is a particular case where someone, again, I suspect this patient, she does have a myopathy, but it just does not show up on the clinical. All right, and so we know what this is. Everybody knows this is hypothyroid myopathy. So thyroid, generally very common cause of, neuromuscular symptoms, although it's uncommon to be the only neuromuscular symptom that someone occurs. So it's pretty uncommon for hypothyroidism just to cause muscle aches in the absence of other symptoms, right? On exam, you might say get some muscle weakness. This is something called myoedema, which I've never seen, but if in patients with severe hypothyroidism, if you stroke the muscle like this, I think this is of this guy's forearm, you can actually get a bulge afterward that will go away in about 10 seconds. But I think this is very commonly tested like a board question, but just to know that a lot of endocrinopathies can cause neuromuscular symptoms and an elevated CPK, of which hypothyroidism is by far the most common. But we have to think about these other ones too. And so usually I'll send, if I have someone who has what I think is some sort of myopathy, I will certainly send things like calcium and parathyroid hormone and stuff like that. I can't say I've ever picked up acromegaly before on my, just from someone coming in with weakness. All right, case number 5. So this is a 48-year-old male, and he's coming in with difficulty walking upstairs. But this has really been slowly progressing over the course of years. But now it's gotten to the point where he has to use the railing. In the past, he used to go jogging slowly, but he hasn't. He stopped that. He hasn't had any falls, fortunately. And he denies any issues with his upper extremities. So when you really push him, right, he does admit that he was always, quote, last in the gym class, right? He was never really, but he never was really like sort of functionally debilitated in the same way that he is now. And there's really no family history of any neuromuscular diseases. So on exam, you do see some abnormalities. So he has proximal muscle weakness. You note he has some no scapular winging. His distal strength is normal. There is some calf hypertrophy, and he does have a CBK that is 385. So again, in someone like myself, right, if I checked my CBK and it was 385, it would not be concerning. But in this particular case, right, if he's having weakness, then this is obviously sort of a concerning finding. So I just want to just touch base on a couple things now. Is just about the muscle exam. So typically, the manual muscle testing, is not that helpful in identifying someone with a myopathy, because it often depends a lot on the patient's baseline. I think it's good to sort of test it over time, but it depends a lot on the patient's baseline as well as really how hard you push. I've always been impressed by how hard like a really good neuromuscular doctor, like let's say Dr. Nair here, how hard she pushes down on the muscles to test for muscle strength. They really go for it. The thing that I like actually a lot more are functional tests. So the one I do a lot in my clinic is the 30-second chair stand. You actually be quite surprised about how some patients. Now, a lot of as we get older, this can be very difficult, but it's a really good way to check to sort of trend someone over time. And we'll ask them to sit and stand as many times as they can over 30 seconds, which is really testing, I think, a better way to test than just pressing against one single resistance. And so I've definitely picked up a few patients with sort of very subtle myopathies because they can only do this, a couple times in 30 seconds, for example. You can also do a similar thing with the arms. So I actually did just order 1 kilogram weights the other day that I'm going to bring into clinic. You can have them do sort of the same, up down with the arm with these 1 kilogram weights over in 30 seconds to try. All right, so what's the differential for our patient, right? So going back to this patient, it's clearly a myopathic process, right? So the differential is, could this be a medication? Well, let's say he denies any medication use. It's really not, this is really not the story of an inflammatory myopathy. By that, I mean something like dermatomyositis, because again, this has been going on for years, right? Inflammatory myopathies will present usually subacutely, so over a period of weeks to maybe months. So the fact that this is really going on for years, and there's really this sensation this could have been going on for a long time, right? So this patient ended up actually having a muscular dystrophy. And I think it's important to remember, there you go. And the calf hypertrophy is sort of a big tip off there. But it's important to remember that muscular dystrophies often in those patients, they're it's not just Duchenne's like in the Jerry Lewis like telethon thing, or Kevin Hart I think is doing that now. But remember there are many different types, and they can be pretty diverse in how they present. And so usually the things you look for is that if they had a family history, although many of these can be sporadic and often they're undiagnosed. But again, they're really sort of very, very slowly progressive. And so again, if you really push someone, you'll note that the weakness extends not just over the past few months, but really over years. And some things that you can often look for on your exam that would be atypical of an inflammatory myopathy would be things like scapular winging or pseudohypertrophy of the calf. But a lot of them can present with sort of proximal muscle weakness, the CPK elevation, even sometimes on the muscle biopsy, you can get inflammatory cells. So typically the diagnosis is made with genetic testing now. So if I have someone who have a muscular dystrophy, I'll talk with Shakti Nair, and we'll send some genetic testing on them at that time. And takeaway number 5, again, some muscular dystrophies can present in adulthood, and you can diagnose them with genetic analysis. All right, case number 6. So now we have a 75-year-old male, and this is, of all the cases I'm going to present, I think this is probably the first one, and then this one is probably the most important. So we have a 75-year-old male, and he's presenting with increased falls for 6 months. He reports that he's fallen in the setting of buckling his knees, but he also tripping over objects that easily he was able to get over. He also notes that he's having some upper extremity symptoms as well, so he has difficulty with gripping objects as well as opening doors. He's noting some dysphagia to solids, so he's noticing some difficulty swallowing. He's not having any muscle pain, and there's no family history of any myopathy. So on your exam, you find that his sensation seems to be intact. You note that, and very importantly, his hip abduction is normal, so he's able to lift his leg against gravity, but his thigh knee extension, so really testing the quads, is a bit weak. You note that he does have some difficulty in dorsiflexion of the ankles. His deltoids are normal, but you note that his deep finger flexors are abnormal. And so unfortunately, I'm not going to be able to show you what I mean by the deep finger flexors, but essentially flexing at the PIP, so not making a grip with your hands, because that's flexing at the MCPs, but flexing at the PIPs and the DIPs. You note that that is abnormal. On exam, you see that he has difficulty making a fist. So unlike this patient here, you can see his fingernails kind of sticking out here. And then you note that, again, he has some very similarly, he has some finger flexor weakness. And on exam, he has some quadricep atrophy, and specifically in the vastus lateralis and the medialis, whereas the rectus femoris here actually looks okay. And notably, again, I want to note this patient had a preserved deltoid muscle. So on further workup, he has an elevated CPK of 1200. His inflammatory markers are normal, and his TSH is normal. All right. So any ideas of what this is? So what do you think this is, and how do we make this diagnosis? Anybody at VHC? There we go. Thank you. We are discussing. Good. So myositis. So this is difficult. So this is an example of what we call inclusion body myositis. Okay, have you guys heard of that before? So inclusion body myositis is the most common myositis above age 50. Oh, you haven't heard of inclusion? You definitely need to know inclusion body myositis, both for your practice, but as well as the boards. So inclusion body myositis is a type of sort of inflammatory myopathy that is probably more primary degenerative as opposed to inflammatory. So this is what healthy muscle looks like, okay? So this is all the paramecium around like this. This is the endomecium within muscle fibers. You can say in inclusion body myositis, you have inflammation within the endomysium. We also see some degenerative features like these abnormal protein aggregates, as well as these rimmed vacuoles here as well. So inclusion body myositis is actually more of a degenerative process than inflammatory, and it usually does not respond to immunosuppression. So again, this is what the inflammation inclusion body myositis, again, is within the endomysium, so it's surrounding individual muscle fibers. And then again, you see these things, these vacuole things on the MRI. And you can see that this is a trichome stain. You can see it a little bit better on that as well. But I think this is really, really important to know because this is actually the most common myositis that presents above age 50 and has a very, very characteristic pattern of weakness. So number one, it really has a predilection for affecting the finger flexors, right? Because it affects the forearm. Remember, the finger flexors that will flex the DIP and the PIP start in the forearm. And so they'll have a weakness with flexing those particular joints. Similarly, the knee extensors are often worse than the hip flexors. So usually, and if you have a myopathy, the largest muscles get affected first. So usually the hip flexors and the deltoids get affected more than the knee extensors. But in this particular case, the knee extensors are primarily more affected, and this is really because its effect on the quads than hip flexion and certainly deltoids. So again, the shoulder is relatively spared, and the thigh flexion is relatively spared. Dysphagia is a very, very prominent problem in this disease, and so if you diagnose with this with someone, you have to train their family on doing the Heimlich maneuver. And then they can often have, in about a third of cases, have a concurrent neuropathy too, sort of a peripheral neuropathy as well. And so this is an MRI for inclusion body myositis. Again, it has a lot of atrophy of this is the anterior aspect of the thigh, so a lot of atrophy of the vastus lateralis and intermedius, but the rectus femoris here is relatively preserved. So again, I really think this is really important for you guys to know, and it definitely will come up on the boards, is that this thing called inclusion body myositis. So I could see a question where they give you the pattern of muscle weakness and say, well, what might be found on the biopsy, for example, or the next best step is, steroids, IVIG, physical therapy. And it's important to know because, again, this disease does not respond to immunosuppression. And so you wouldn't want to give someone immunosuppression and a potentially toxic therapy like prednisone, right, for no good reason. And so if I ever have someone referred for, quote unquote, refractory polymyositis, I almost always, the thing that I think about on the top 10 things that I think about is inclusion body myositis, because it's relatively uncommon for patients with, or sometimes maybe even a muscular dystrophy, but it's relatively uncommon for someone with inflammatory disease not to respond to something in the armamentarium that we have these days. So again, please just remember inclusion body myositis in your practice. All right, case number 7. So we have a 60-year-old female. I'm sure I feel like I gave this just the other day, so I'm sorry if I'm repeating myself to anybody. We have a 60-year-old female. She has a few weeks of proximal muscle weakness, also endorsing some falls and myalgias. She'd never had anything like this before. She's got really no extramuscular features, and her CPK is 14,000. And she was admitted to a hospital center. They said she was on Lipitor, and so they said, oh, you have a statin myopathy. They gave her some fluids. I think the CPK probably came down to like 8,000. She was feeling a little bit better, and so she was discharged and said, hey, follow up with your PCP. But 2 weeks later, she came back to Georgetown, and her CPK is back up to 12,000, again with similar symptoms of proximal muscle weakness, falls, and myalgias. So what could be going on here, right? We thought her symptoms were related to her statin. Her medication was appropriately stopped, and yet she still continues to persist. So I just want to talk about the muscle findings that you can see in statins. So on the one hand of seriousness, people can get myalgias. Now, it's actually controversial of whether this is a true side effect of statins or not, or more of what they call nocebo effect. There's actually a study that's coming out in the New England Journal in the next couple of months that shows that probably the vast majority of myalgias occurring with statins is due to what they call nocebo effect, meaning Your brain is telling that you're having myalgias, but it cannot differentiate between statin and placebo. Then as you get sort of on more severity, you can actually get what we call a toxic myopathy, meaning that the statin itself can cause muscle damage, which will lead to a high CPK and actual weakness. And this is actually related a lot to the sort of degree of exposure. So meaning that patients who get this might have genetic polymorphisms in proteins that take up the statin from the blood. So if you have an abnormality in that, you might get more sort of systemic statin exposure, for example. But really importantly, and that occurs maybe in one of every, I don't know, 2,000 or 3,000 people. Importantly, right, if you stop the statin in that particular case, right, your muscle symptoms will get better. Now, in the last, I would say 10 or 15 years, there's been this recognition that statin can cause what's called an autoimmune necrotizing myopathy, meaning that it can cause, the statin themselves can trigger an autoimmune process that leads to muscle inflammation and muscle damage. And stopping, in that particular case, stopping the statins in and of themselves is not enough. So in addition to stopping the statins, you will need to give them immunosuppressive therapy, as in this particular patient that we said. So I just want to talk, there's a pattern of muscle involvement that we call immune-mediated necrotizing myopathy. And essentially what that means is that you basically get a lot of, on the muscle biopsy, you get a lot of degeneration and regenerating muscle cells. You get a lot of macrophage infiltration, but you actually don't get a lot of primary inflammation from lymphocytes. So C and D over here are staining for B and T lymphocytes, which you don't see, or in contrast, you see a lot of macrophages. So this particular muscle biopsy pattern has been known about for a long time, but only, I would say, in the last 10 to 15 years have they realized that, have they identified that an antibody specifically that this muscle pattern is associated with this statin-associated autoimmune necrotizing myopathy. So this disease, again, is a very, very severe disease, unfortunately. It's relatively uncommon, but I think I probably have maybe, I don't know, between 5 and 10 patients who I follow for this. And, again, the key important point is if you have someone who has stopped the statin and yet their weakness, their CPK is still elevated, right? And this is not someone who just has some muscle aches. This is like very severe weakness and a very, very high CPK. They need to think about this particular disease. It's really, really quite important. All right, so our last case. So we have a 52-year-old female, and she's endorsing 6 weeks of proximal muscle weakness. And she's really noticed this, like when she walks upstairs, when she brushes her hair. The review systems is pretty positive. So she feels feverish. She's not sure if she's had an actual fever. She has fatigue. She has noticed some unintentional weight loss, which again is always a big red flag for something. It doesn't mean you have an inflammatory disease. It could mean you have, in your elderly, it could mean they have depression. It could mean they have, thrush, and so they can't eat that well. There could be a problem with their dentures, but that's always a big red flag, is unintentional weight loss. And these new cutaneous features. She has a CPK of 4,000. She has elevated inflammatory markers. And then again, she has this AST and ALT that are elevated, but this is probably a muscle source, as we kind of talked about before. So again, this here is a good story for dermatomyositis, right? It's a good story for an inflammatory myopathy, meaning that, yes. Meaning like it's relatively subacute. So it's not hyperacute. It's not like you wake up one day and suddenly have dermatomyositis from Monday to Tuesday, in the same way that, like, for gout, right? It'll wake you up in the morning, you'll go to bed fine, then you suddenly wake up the next day with severe joint pain. It's not really, it really evolves over, I would say, weeks to maybe a month or two. And in addition to the muscle weakness, right, you have these other features, right? So you have kind of feeling fatigued and feverish, and now you have these cutaneous features. They have elevated inflammatory markers, right? So it's more, just think of it as more of a systemic disease process. This is what we call the heliotrope rash. So the heliotrope is a type of purple flower. And then it's also, the heliotrope rash, often you'll get a lot of eyelid edema. So I had a patient whose really only clinical feature was very severe edema in the eyelids. This is what we call V sign due to dermatomyositis, right? It'll occur kind of on the chest. Shawl sign is a very similar looking thing that occurs over on the back there. Gottron's papulas are raised and they're over the MCPs and the PIPs in the hands. Gottron's sign is usually over the knees or elbows, and typically it's not as raised. You often will get a lot of nail flow changes in the same way that you do in scleroderma. So you can see all these dilated capillaries here that you can see. You can actually get calcinosis cutis, although this is relatively uncommon. Mechanics hands is very something is associated with something called antisynthetase syndrome, which I would say is sort of a subtype of dermatomyositis in which you have very strong predilection for joint and lung involvement. And this is what you'll see on the muscle biopsy. So in contrast to polymyositis, where a lot of inflammation is within the endomysium, in dermatomyositis, most of the inflammation is around the edges of the paramecium here. And then this buzzword that, again, I think you should probably, I'm not sure if you'll need to know for your boards, but it's called perifascicular atrophy, meaning that the muscles closest to the paramecium, so down here, are the ones that end up getting atrophic, right? In contrast to these muscle fibers look good, but the ones down here, and they look atrophic. So that's a very, very characteristic features of dermatomyositis on biopsy. So if you see, it's not seen on every biopsy, but if you see that, right, you should really think of dermatomyositis. Again, poly, the inflammation is within it's endomesial, so sort of within the muscle fibers themselves. All right, so our last takeaway, again, if you're thinking about an idiopathic inflammatory myopathy, so either dermato or polymyositis, again, look for a subacute course that usually progresses, right? So people get worse over the weeks that they have this. It's uncommon that they have actual muscle pain with this. They're very, very frequent systemic symptoms, and again, look for these extramuscular features, right? So not just cutaneous, but also articular, pulmonary, are other things you would think about.